Okay, it's fine. Welcome to this session. My name is Mario Possenti. I'm Secretary General for Federazione Alzheimer Italia and Honorary Secretary for Alzheimer Europe. So today we have a parallel session on the RECage project. RECage stands for Respectful Caring for Agitated Elderly. It's a project funded by Horizon 2020. And today we have 4 speeches and 3 speakers that will introduce us the project, and we'll go through how we will possibly end this project next year. So our first speaker is Sara Fascendini. She's a geriatrician and the medical director of the Third Alzheimer's Center at the Briolini Hospital in Gazzaniga. Please, Sara, the floor is yours.
Hello, hi to everyone. I'm very pleased to be here and grateful to can explain to you our project that we started almost 5 years ago in 2018. Oh, okay, thank you. So, no, the green one? Okay. So the project tackles one of the most relevant problems in the field of dementia that are the so-called BPSD, or what we named in the past behavioral and psychological symptoms of dementia. We have knew for many, many years that this kind of symptoms are leads to very negative outcomes, such as diminished quality of life, both for the patients and the caregivers, excess of disability, caregiver stress, significant financial costs, and premature institutionalization. But we also know that we have for a long time looked at this kind of problem in a wrong way, using a so-called broken lens. We have interpreted these kind of symptoms as part of the disease, while they are more often a kind of answer from the person with dementia to Okay, thank you. An answer from the person to some triggering situations. And so if we wondered years ago about the so-called behavioral crisis, and that are episodic crisis that leads to a stressing situation for the person with dementia and their caregiver. And so we decided to write this project that has been funded by the European Union. And the major objective of RECage is to adapt and scale the implementation of a peculiar intervention aimed at controlling BPSD. That is the special care unit for persons with dementia and BPSD. The intervention is already implemented in some European countries, but is not widespread, and had not been sufficiently studied so far, although it seemed to be promising, both for its short-term efficacy and possibly for its long-term efficacy measured as delayed of nursing home placed. So, what is a special care unit for BPSD? Our definition is a residential medical structure lying outside of a nursing home, in a general hospital or elsewhere, for example in a private hospital, where patients are temporarily admitted where their behavioral disturbances are not amenable to control at home. The mission of the SQB is to improve patients' behavior, and its goal is to permit, when possible, his coming back home. But how does a SQB works? The therapeutic approach in most of the existing SQB in Europe is a mix of cautious pharmacological treatments, rehabilitative and non-pharmacological therapies such as occupational therapy, physiotherapy, doll therapy, pet therapy. All these therapies are given in an appropriate environment, and most of all, there is an availability of staff, expert and trained. The staff is a multidisciplinary team composed of doctors, psychologists, educators, occupational therapists, physiotherapists, nurses, and healthcare professionals in general. In some existing SQB, patients' approach is in line with the gentle care of Moira Jones or the person-centered care of Thomas Kitwood. So 5 years ago, we composed a consortium of countries in Europe. The consortium is composed of 11 clinical centers, 5 of them with SQB and 6 without. And these are the clinical centers. The first one is our center in Italy, near Bergamo, in the northern part of Italy, and we are the coordinator of the project. And then there is Norway, Switzerland, another center in Italy that is in Modena, that is the only other clinical center in Italy that has SQB. So Italy and Greece are the 2 countries in Europe that are in which SQB are not well spread. While in France, for example, there is a big diffusion of these words. There are almost, I think, 100, and they are called the Unité Cognitive Comportamentaux. Also Greece, Germany, and then other centers in Italy without SQB. These are the technical and political participants. So the University of Maastricht in the Netherlands, the Regione Emilia-Romagna in Italy, Federazione Alzheimer Italia, and 2 lay association in Greece, which with Italy is the other country in which we would like to scaling up this kind of facility. The project is composed of 3 phases. So the first phase is a trial, an observational comparative cohort study in which that will last 3 years, is lasting 3 years, comparing 2 cohorts of persons with dementia with severe BPSD. The first cohort is followed by memory clinic endued with SQB, and the second one with centers lacking this facility. The main objective of the trial is to demonstrate the superiority of the SQB in terms of reducing the BPSD and improve the behavior, and most of all, improve the quality of life of persons with dementia that can go back to their homes. The second phase of RECage is to adapt the model in accordance with the results of the cohort study. The result will be ready in a few months at the end of December this year, 2022. The third phase is the scaling up the intervention. So I show you just a few slides, and then my colleagues will show you deeply the results and the future of our project. So we started the project it would be January 2018, but the first person enrolled in the study was in April 2018. At the end of the September 2019, we reached the goal of 500 persons included in the study. We have 518 persons in the study. So most of them have a diagnosis of Alzheimer's disease, while the other, as you can see, mixed dementia or vascular dementia. As you can see, the mean score for the PSD is quite high, as with a total MPI score of above 50 in all both the two cohorts. And this is the same for the Cohn-Mansfield agitation inventory. So we published the first paper last year, I think, yes, 2021, about the rationale and design and methodology of the trial, of the cohort study, in which you can, if you are interested, you can find all the details of the trial. And another paper has been submitted a few weeks ago, and is about a qualitative study about the project that I will talk you about in a few minutes. As I said, the project has started almost 5 years ago, and the trial is already quite finished. We had some big problems during the pandemic, especially during the first months of the pandemic. My center is located in the very in the part of Italy in which the COVID struggled more in 2020. Our center is located in a town called Gazzaniga, that is few kilometers away from the well-known Nembro or Alzano Lombardo, that are the focus of the pandemic. And so we had some big problem, but we managed them, continuing to do mostly phone visits during the first months of the pandemic, and also did our partners all around Europe. But for these reasons, we decided to ask the EU for an extension of 6 months of the project, and this has been accepted. Therefore, the project will last 66 months instead of 60, and will finish at the end of June 2023. At the end of the project, a final conference will be organized, and my colleague Andrea will tell you about it in a few minutes, in which we present the result of the project in order to produce a consensus document on a models QB. And these are the milestones of our project. So this is a wrong date. The closing conference won't be on 14th, but on 21, 21st, 22nd of February 2023. And so thank you for your attention, and I will answer some questions after all the presentation. Thank you.
Thank you, Sara. Thank you, everyone. Now it's time for Aline Mendes. She's a geriatrician at the University Hospitals in Geneva. She will talk us about the first results, partial results of the study. Please, Aline.
Thank you very much. Good morning. It's a pleasure to be here to talk about this subject that is somehow a little bit neglected for those who work in this field. I work in the University Hospitals of Geneva, and I am in charge of a special care unit that exists since 2009. It was created mainly because we wanted to have a solution to figure out why patients with dementia, people with dementia, were transferred from internal medicine, geriatrics, psychiatric wards, neurology, and we just wanted to give them some better quality of care. And this is how those types of units were created across Europe because of some local unmet need of different health systems. And we try with the RECage project to put all together and understand what are our common values, what we need to widespread this type of care. Green button? Ah, okay. So this is the outline of my presentation. I just did some background on the subject, and I will talk a little bit about the study, some methodological aspects, and a little bit of results and follow-up. So I will refer as BPSD, as Sara did, for these behavioral symptoms, and it's very different, very interesting to look to see that those symptoms appear during the whole presentation of dementia. Even years before the first cognitive symptoms, people can already express behavioral and psychological symptoms related to the future disease, such as irritability, mood disorders, and sometimes sleep problems, and sometimes, most of the times, several years before dementia. And almost every person with dementia will present at least one of those symptoms. And most of the times, they will have multiple symptoms in a concomitant way, which is very complex to manage in clinical practice. So BPSD is also related as a frequent reason for admission in nursing care homes. We know that specifically agitation and aggression are very correlated with depression and social functioning among caregivers. So the behavior of the patient, the person with dementia, will also reflect on what is going to happen with our caregivers. And this is very, very important. And BPSD is also something that is going to accelerate the dementia process and functional decline. It's very complicated because, as Sara said, we use it to refer it as symptoms. BPSD is the main term used. But at the end, it's a way of communicating for these people. It has lots of distress among caregivers and interdisciplinary teams, but it's a meaningful way of communication for those people. So we really try to understand how we can manage them the best we can. And in the main management of those patients, we have the non-pharmacological interventions, sensory interventions, psychosocial interventions, training, formation, education of caregivers, interdisciplinary teams. But how do we choose among everything that exists? Is this person going to respond to music therapy, to sensory stimulation? How can we combine all these things that exist? And this is very difficult because the scientific literature is not going to answer this to us right now. And that's why, for me, the special care units are, above all, an opportunity, because it's a way to refer patients to a specialized team that can, for a short period of time, try to test and retest what's going to work as intervention for those patients and those caregivers. It's very difficult to do it for outside patients. I also work in the memory clinic. It's a completely different scenario from the hospital. We don't like to hospitalize older people neither, but special care units may be an opportunity to solve this puzzle. I also mentioned physical restraints and use of antipsychotics and sedatives because we don't like to use them. They are contraindicated. So special care units are also an opportunity to train people and caregivers and avoid using things that are not going to help the persons with dementia. So Sara already gave you the definition of these special care units. So they are not units in nursing homes. We also observe a development of special care units in nursing homes, but we are talking about a healthcare system, not a place of living. Those units are located in the healthcare systems. And we also know that there is no uniformity among the existing units in Europe. And this is okay, because we are all different. We are different cultures, we have different health systems, and this is not a problem. What we need to know is that medical treatment and interdisciplinary team and organization follows the current guidelines, and that we have the same values of the management within our differences. We also know that the short stay in these special care units can improve BPSD, but how about the long-term efficacy of these units? And this is a big question, because the differences are important, but for clinical research, they are also a challenge, because it's very difficult to combine methodological aspects, to study all these different units, to see, is it really going to help in the long term to avoid nursing home admission, to help caregivers to stay longer and avoid burnout, distress, depression, and other deleterious consequences of BPSD. There is this paper from 2009. It's a meta-analysis, I think one of the most important ones in this field. In 2009, they were able to combine 8 papers in this meta-analysis, which is a very reduced number of papers. And the results, they tried to search all different types of outcomes, use of physical restraints, control of the behavior, admission to nursing home, and their conclusion was that a convincing case for the benefits of those special care units could not be made, and that further studies are necessary. This was in 2009. There were different studies since then, but the conclusion remains the same. And it's important to tell this because the RECage project was born in this unmet need to answer this question. Do we need to widespread these special care units across Europe, and how can we do it? And what can we wait as a result, as a meaningful result for people and families? So why is it so difficult to study this subject in clinical research? First, because pathophysiological mechanisms of agitation, aggression, and other BPSD are poorly understood. We know that it's something related with the dementia itself, with the disease that is occurring, but also it's something that can also be understood as a response to the environment, to the physical, social, emotional environment. So it's very difficult to understand the reasons underlying those symptoms. The other issue is that the efficacy and tolerability of available pharmacological and non-pharmacological treatments are also poorly understood. As I told you, how can I combine interventions for this family? Do they need psychological support, music, physical activity? How can I choose among everything that exists what is going to work for this given family, person with dementia and caregivers? The development of new pharmacological options, I think it's important to talk about this because we see this movement towards the research to treat very early stages of cognitive impairment, which is very good and important. But people still have dementia, people still have behavior symptoms of dementia, and maybe we could also have some pharmacological progress in this field, which is not really the case right now. And large prospective trials are needed to establish this effectiveness of these different approaches. So the RECage project, so respectful caring for agitated elderly, our main objective is to evaluate the clinical efficacy, both in short and long term, of the special care units. And we chose to measure this by assessing quality of life of patients and their caregivers, cost effectiveness, which is a very important point for different health systems across different countries in Europe, to estimate the psychotropic drug consumption over time, to assess the change of attitude of caregivers towards dementia, and to assess the capacity of these special care units to delay admission to nursing homes. So this is a 3-year prospective observational study comparing these two groups. So we included centers in which those units exist, and patients and people with dementia and behavioral symptoms were admitted for a period of stay in these units. And we compared to other centers in which those units do not exist, so they have their standard care without special care units. So why we did it? Because we think that in the systems, in the health systems in which those special care units exist, quality of care is superior. Mainly in these 3 aspects: the quality of life, the changes in quality of life and in attitude towards dementia. We think that by being admitted to a special care unit and being in contact, even if it's for a short stay with this specialized unit, interdisciplinary teams can enhance the quality of life after discharge, and knowing that it exists if the person needs to be readmitted. We also think that cost effectiveness can be superior and psychotropic drug consumption, because they will benefit for some periods of tests of these interventions, and we could delay admission to nursing homes. So these are the centers, as Sarah already told you, across Europe, from Norway, Germany, Italy, Switzerland, and Greece. So I will show you a few characteristics of the population included in this study. This was very important for us. Who are the people with dementia included in the RECage project? So their mean age is of 70-80 years, 55% of women, and 80 years of study. Alzheimer's disease, multiple etiologies, vascular dementia, and dementia with Lewy bodies accounted for 85% of diagnosis. And 80% of people with dementia had multiple comorbidities, most of them cardiovascular. I find these results very interesting because when we work with people with dementia, we can develop sometimes a tunnel vision, and we see the dementia problem and we think the person is agitated because it's a symptom, it's a manifestation of dementia, but actually he has problem to breathe, he has some pain that is not well controlled, and it's very important because we know that multimorbidity is very prevalent with aging, and it was very important to reflect that in people included in this study, because it's not only dementia the challenge, it's dementia, heart failure, diabetes, articular problems, renal failure, and other medical issues. And then the neuropsychiatric inventory, for those who do not know this scale, it takes into account 12 symptoms, as you can see. Each symptom is assessed by a structured interview with the caregiver, and we can assess for the presence, the severity, and the consequences of the behavior problem symptom. And as you can see, it's a scale that goes from 0 to 144 points. 144, it means there is very high burden of behavioral problems. And the mean NPI in baseline was 52, which is very high. To participate in the RECage project, they need to have more than 32 points, so they had 52 at baseline. And who are the caregivers in the study? This is also very important. As I told you in the beginning, we cannot investigate anything in people with dementia and behavioral symptoms without taking into consideration the caregivers. So in the RECage study, we have 38% of caregivers who are the spouse, 56 a child of the person with dementia. They are 62 years old, mean age, and 70% are women, which is something that we know from previous study. Most of main caregivers, informal caregivers, are women. And we assessed for their well-being, taking into account these 5 domains: physical and emotional health, social relationships, development, and time dependency. We used the caregivers' burden inventory, and as you can see, they had a mean value score of 36. As you can see, I put the first 0 to 24 is mild burden, moderate, and severe burden. So 2/3 of our caregivers had moderate or high burden, which shows the need to develop standardized interventions and help these families. So we included 535 people with dementia in this study. We just finished the 24-month follow-up. It's a 3-year follow-up study. We had so far 18% of mortality, 96 patients. As Sara told you, we continued this study during COVID, which really impacted our follow-up and the clinical trajectories of our people included. 29% of people with dementia were admitted to nursing homes, and more than a half is still at home. What we would like to know next, and this is what we are doing right now, closing up the study with the 3-year follow-up, is to know in these 3 different trajectories to compare the centers with special care units and without special care units, and see if we find any differences among these outcomes. So, among the reasons, the causes of mortality, the 18%, we have infections, cardiovascular disease, we have COVID, stroke, and unknown causes. Medical occurrences, this is also very interesting because, as you can see, almost all persons included in the study had at least one adverse event since the inclusion. which reflects the fragile characteristics of this population. We classified them as accelerated cognitive decline or functional decline, Parkinsonism falls, which is very frequent in this population, injuries resulting from falls, and agitated and aggressive behavior. So our perspectives, in a few weeks, in November, we are closing up the results from the third year of follow-up. It's the final year of the follow-up of the study. So we'll be able finally to compare the different populations and the centers and understand what impacted the trajectories of our people with dementia among these different countries, taking into consideration the presence or the absence of special care units in each country. So this is it. If you want to follow up on the results, you can go to our website to check what's going to happen next. And thank you very much.
Thank you, Aline. Thank you, Aline. We will keep the question for the end of the session. Again, Sara, this is your turn again. We would like to know more about the parallel study that runs with the RECage trial. Thank you.
Okay, it's me again. Unfortunately, our colleague Anna Giulia Guazzaridi from Perugia couldn't come, and so I tried to manage this qualitative study. No, we have the first slide. As Aline just said, we are all different. We come from different countries in Europe, but we have one objective, and we know something about what we do in our clinical wards. And the main objective in our study is to catch the main goal, catch the core of this unit in order to scaling up and hopefully scaling up this facility in Europe. So, as I have just said, the RECage clinical trial is a multicentric, multi-country study carried out in existence QB with some common features, but with not little differences. Above all, they are embedded in different healthcare systems and different social contexts. So, all our countries have health and long-term care system differently organized. All health systems are funded on universality, solidarity, and equity, but the differences between them reside above all in how the different services are financed and operated. So the RECage project proposed a transversal analysis of experiences coming from 3 different care regimes that are the familistic care regime, such as in Greece and Italy, a mixed care regime, such in Germany and Switzerland, and a universal Nordic care regime, such as in Norway. So, when we realized that the future results of our study would not be correctly interpreted without the concomitant qualitative study that explore the different centers' social context, we decided to do this qualitative study aim to explore the QB units to describe their main characteristics related to different implementation contexts and to identify the characteristics of its replicability. The qualitative study was conducted between 2019 to 2021 in each center participating in the project. And as I already said, there is a paper that has been submitted and hopefully will be published in a few months. So, as I said, the study was conducted in all the center, and the research work is composed of 2 steps. The first one was the reduction of a country form, and the second one is the realization of a qualitative study by interviews and focus groups. All participating centers filled out a detailed form on each country's socio-political context and regulatory framework to clarify the long-term care and health context in the country involved. We collect also the technical requirements of the SQB, if there was a SQB in the center, and this form was mailed to the principal investigator that collected all the questionnaires and produced a written response. About the focus groups, the main topics discussed was both from the focus groups and the interviews were to highlight strengths, weaknesses, opportunities and threats of the SQB using a SWOT analysis, to identify the social innovation, the possible social innovation promoted by the SQB, and to identify the scaling up characteristics of the SQB. These are the participants to the focus groups, and the number of the participants varied from 5 to 12 in each group section, and the total number of the focus group performs was 18, involving almost 140 participants. The number of experts and stakeholders interviews was about 250. As you can see, the profiles of the participants, both at the interviews and the focus group, were internal professionals such as physicians, psychologists, neuropsychologists, nurses, rehabilitation technicians, occupational therapists, and local stakeholders such as social and health authorities, NGOs, participants such as from Alzheimer Association, Family Support Association, private care providers, informal caregivers, or relatives of persons with dementia. As you can see, there is a big lack in these participants that are persons with dementia. We struggled to have some people with dementia in our group, but we didn't succeed in it. And this is our desire for the future, to include people with dementia in the future groups that will lead to the final document about the SQB. The focus groups and the interviews designed some common characteristics in our SQB that are related to the unit itself, that is commonly defined as a specialized ward for the treatment of behavioral disturbances, independent from other wards or other facilities, but commonly inside a hospital. In this facility, there is always some informal caregiver support group that are considered very important to develop a relationship and with the caregivers. The follow-up of people with dementia occurs every 6 months, and there are regular and scheduled checkups for clinical and pharmacological re-evaluation. Very often it has been considered very important to have control at home after discharge from the facility. The care is very personalized, and as I said before, follows the gentle care of Moira Jones or person-centered care of Thomas Kitwood, and the psychosocial interventions such as Kitwood's ones are very common in our words. In this facility, these are rehabilitation facilities, and the rehabilitation activities are central in the development of the care trajectory. And then there is the possibility to have healthcare professionals such as physiotherapies, speech therapy, occupational therapies. The team. The core of the intervention is funded in the team. That is a multidisciplinary team, well-trained, expert, and with continuous training lasting many years. And the healthcare professionals come from different areas with a different professional background, and they are united in a team for the purpose of planning and implementing treatment programs for complex medical conditions. Another very important point is that these wards are have a big and active local network around them. For example, in our case, we are deeply involved in the dementia-friendly communities system of our countryside, and also for the other wards. So, what about the SWOT analysis? As regards the internal factors, such as strengths and weaknesses, the focus group underlined that the strengths are concerned the well-trained expertise, multidisciplinary teams, the continuous education of the staff, the person-centered approach, the psychosocial intervention, the possibility to optimize the medical treatment, the dementia care network around the unit, and no restraint policy in the clinical wards. About the weaknesses, often these facilities are not all integrated in the dementia care network. Sometimes they are private, in private healthcare structures, and they have sometimes lack of resources, lack of ward space. It is very difficult to provide correct follow-up visits after discharge, or too high concentration of patients with solid needs. About the external factors, such as opportunities and threats, the more important opportunities were the presence of dementia-friendly communities around the facilities, the possible admission directly for the emergency room. That is not common in all facilities, but in some of them, good cooperation with outpatient services and nursing homes, involvement of the caregiver during the stay and the preparation for discharge, continuous training of the staff, debriefing sessions, presence of many specialized services potentially available to new collaboration. And about the threats, the social stigma is the biggest one due to the hospitalization in an Alzheimer wards and ageism, stigma related to mental health facilities, the organizational difficulties within the hospital structure and in the cooperation with other hospitals. It is a stressful job. Very often our healthcare operators are going into stress or burnout, and service is not known enough to family, caregivers and stakeholders. Sometimes we see unrealistic family expectation about the results of the staying in our facilities. We talked a lot about the replicability of this unit, which seemed to be not so easy. Most of all about the replicability of the whole facility, the whole unit, while some characteristics of the unit seem to be more easily replicable. And you see the elements of the units and the level and agreement. And you can see that almost all that characteristics have half and half possibility of to be replicable in other units. And I remember you that is a goal, an objective of our project that is the scaling up of these units. And we hope we can do that at least in Italy and Greece, that are the countries in which this facility is not well spread. And to conclude, I think this kind of analysis, so a qualitative analysis, allow us to go deep in the meaning of our work, and it is very important to listen to what our healthcare professionals or caregivers or even persons with dementia have to say about these kind of facilities. These are some statements that the participants to the focus group made, and you can read it and understand that is a problem that is not well known in Europe, maybe in Italy, and also in other countries of our consortium. And I think that this QB could be just a little piece of the care pathways for people with dementia, but it could be useful to living well with dementia. As a participant said, SQB could play an important role in the dementia care network, as they seem to be a missing part of the puzzle. And thank you for your attention.
Thank you, Sara. Our next speaker is Dr. Andrea Fabbo. He's a geriatrician from the Health Authority in Modena. He will talk about the consensus conference, which will be at the end of the project. Thank you.
Il pulsante verde era? Ok. For the slides. Okay. I'm very pleased to be here, and thanks to Alzheimer Europe for this opportunity and Alzheimer Italia for this important study. The consensus conference. Sempre quello grande. Ok, thank you. Okay, we discuss the importance of RECage project. The mission of SCOBY, said Sara, is to improve behavioral and to permit, when possible, their coming back home. These recommendations are present in ALCOV project because the place dedicated to BPSD in Europe is a very, very important. As this research has already shown to be of a dramatic help for people experiencing major BPSD in several European countries, but is little studies. And the model, the ALCOV, provided a care organization for BPSD, a minor BPSD prevention and management, a major BPSD crisis management, and SCOBY to serve for this crisis, and the BPSD management and prevention. In our network in Italy, we have a special care unit in nursing home and a special care unit in hospital. But we think to demonstrate that this word is necessary in the network of services. This is a work plan of the project, of RECage project. We concluded work page 3, data analysis, for December, and we have work pages 4, work pages 5, and work pages 6 after the consensus conference. This is the original RECage work hypothesis. It was decided to adopt a research design that included one identification of the type model of SCOBY, of its day intervention and processes, and the standardization of the necessary intervention after adaptation to the different assistance realities present in the different European countries. Work with people with BPSD, plus short stay in SCOBY with the aim of alleviate BPSD and improve quality of life and delay nursing home placement. This is the RECage consortium research, different type of professional, medical doctors, nurse, psychologist, occupational therapist, and sometimes types of stakeholders. The work pages 4, adapting the intervention, have as an objective of to reach a consensus upon the recommended characteristics of these SCOBYs after the analysis of the study results, to know barriers and facilitators either for adapting the intervention, to organize a consensus conference as results of these studies. This is the tasks of work pages 4, adapting the intervention. The original proposal was preparation of the nominal group technique, or the organize a conference, and writing the position paper, guidelines for the establishment and operation of a model of SCOBY. But we have some risks that must be eliminated. FERB and Perugia University are working on the results on the qualitative study, said Sara. Their manuscript is expected before November 2022, where experts will carry the analysis of the trial results in December and share them with all of us. As Emilia-Romagna regions, member of consortium, we proposed to perform a systematic analysis on the literature on the SCOBY, and we discussed this with the experts of the Institute of Neuroscience, Alma Mater Studiorum of Bologna, and choose the target, the analysis. According to the National Health Consensus Development Process, Scientific evidence is the basis for making judgments and statements. Panel members will receive a formal synthesis of the literature, systematic reviews, evidence mapping, scoping reviews. But we have these research questions. What kinds of SCOBY are there? What are the main issues related to the SCOBY? What is the evidence of clinical effectiveness of the acute SCOBY versus usual care? What is the evidence of cost effectiveness of the acute SCOBY versus usual care? What are the safety issues of physical restraints and neuroleptic treatments? In these slides, we summarize these questions. These questions and the use of literature to support this model. Open questions, description and technical characteristics of SCOBY, target population, architectural, organization, legal aspects. Fifth problem, must we change the original definition of SCOBY? Second problem, are there different kinds of SCOBY? We have SCOBY inside the acute hospital or connected with the acute geriatric wards, or we have SCOBY outside acute hospital as a rehabilitation facility, Gazzaniga or Modena, or psychiatric hospital, Mannheim or Ottestad. This difference probably explains the different lengths of stay. Other question. The third problem, we are facing two alternatives: to develop the minimum common denominator of a SCOBY ward or the optimal set up for a SCOBY ward. And fourth problem, what are the minimal optimal structural requirements of SCOBY, architectural standards, staff number, or nursing model? And what are the main ethical issues related to SCOBY? Informed consents, restraints, benevolent coercions. Another question, what is the evidence of clinical effectiveness of the SCOBY versus usual care? The data of RECage study, the data of the scoping review we will prepare in Emilia-Romagna region, and the draft of the qualitative study described from Sara. And the question 3, what is the evidence of cost effectiveness of this SCOBY versus usual care? The participants will access to RECage data and to the scoping review. And the question 4, what are the main safety issues of restraints of neuroleptic threats? This is a problem. This is a problem because we not have a sufficient number of studies in this direction. The participants will have access to the scoping review and, among other papers, such a report of Dementia Australia, the use of restraint and psychotropics medication, and another documents in Australia regarding the decision-making tool supporting a restraint-free environment. But we don't have other type of documents. We need of 3 key words for SCOBY: prosthetic environment, activities such as occupational therapy, or staff training. This is best practice in dementia care. Better quality of life for people living with dementia who experience behavioral problems. The research hypothesis for scoping review is elaborated with PICO, patients with dementia and behavioral disorders, intervention, special care unit, rehabilitation unit, somatic dementia unit, specialized geriatric unit, specialized psychiatric unit, gerontopsychiatric unit, unité cognitive comportemental, the French model, control, standard of care, admission to emergency room, plus medical and psychiatric wards, and outcome, hospitalization, institutionalization, quality of life at the cost, psychotropic drug consumption, and and assessment, and the geriatric assessment. Some pioneering papers and some more recent studies demonstrated marked improvements of BPSD during a short stay in SCOBY. These statements were based on a non-systematic perusal of the literature. That is why the importance of a new, updated systematic analysis can hardly be emphasized. This analysis, together with the results of the RECage clinical trial and the data coming from the qualitative study, will represent a solid evidence on the basis of which we have to implement the work pages for, with the aim to produce a consensus document on the recommended characteristics of this SCOBY. Recently, a new entry of Institute of Neuroscience of Bologna suggests to choose the model of a consensus conference instead of the nominal group technique as originally planned. In fact, the grade of evidence from the literature is not strong, and the problems we meet during the trial, including this COVID-19 crisis, raise some doubts about the probability of reaching our endpoints. According to this model, we need to choose a sponsoring institution, Alzheimer Europe, a scientific committee, and 4-5 expert groups requested to answer the main research question. Each group shall receive before the conference the results of the above studies and shall prepare some provisional statements to be presented by its spoken person during the first consensus session. We need a panel of experts. The panel will separately, during a closed session, discuss the statements proposed and choose those that seem most appropriate, and the panel chair will disclose the statements accepted before the general public during the second morning of the conference. This is the next conference, consensus conference, we will organize in Brussels for February 21 and 2022, and these are all the partners of the projects. The first day, Thursday, 21 February, we dedicate to the presentation of the results of the RECage trial, the presentation of the results of the collateral qualitative study, and the presentation of the results of the meta-analysis. In the afternoon, we will share the presentation of the statements produced by the 4-5 expert groups. The second day, the chairperson of the panel shall present the statements accepted of the modified and the general discussion open to the public will issue. A final document will be written after the conference involving the project coordinator and widely circulated and disseminated. We hope that the quality of life for people living with dementia who experience behavioral problem or meet needs can be better. Thank you for attention.
Thank you, Andrea. We have, if you want to, if we have some questions from the floor, please. You can help us, Andrea, with it.
For me?
I would really like to thank all the speakers for this very interesting presentation about RECage. The daycare centers where I work is part also of your team, Greek Alzheimer Association. You mentioned about the school bees admission, but we all know that when a person living with dementia goes away from the home and changes the environment, perhaps the levels of agitation and safety will increase because the new environment is unknown. So this sense of unsafety maybe is related with the behavioral problems. Do you have any plans about what can you do to cope with possibly unexpected unsafety and, yes, stressful symptoms?
Thank you for your question. I think the first thing is to know what we want from this admission to the hospital. We need to have clear objectives so we can know that the benefits are higher than the adverse effects of the hospital admission, okay? Then what we do, in my experience, we try to integrate the best we can the family during the hospitalization. We try to change a little bit the environment to know the best we can the routine of people with dementia and try to mirror that during the hospital stay. And even the decoration of the room, we try to change, to modify according to putting objects that are familiar to patients, to these people and families, so we can change a little bit this safety issue. I think the other thing is the training of the interdisciplinary teams with the constant reorientation of people with dementia and families. This helps a lot. And in my experience, this is what we try to do.
Yes, also for me, this is a big issue, but as we said, the correct admission to the ward is when we have a behavioral crisis, a severe behavioral crisis that is not possible to manage at home. In this case, as Aline said, the advantage of the admission could be superior than the disadvantage, you know? But it is an issue, a common one.
Thank you.
Congratulations for the great work you have been doing. I understand that the data analysis is to be done, but I would like to ask your educated guess. What is your impression? What do you expect to be presenting in February? I bet you would have an idea already.
So, it will be really difficult to get some strong results for the analysis, most of all because of the differences in our words. And this is the reason for which we decided to do a consensus conference and literature analysis and to do a qualitative study. And so we are all expecting these results, and we hope our statistician and our economic expert can manage the mess of data they have. But we don't know. We are hoping. Okay.
Thank you.
Maybe you can come in February in Brussels and see the results, and then we will publish the paper, a consensus paper about it.
Okay. In our clinical practice, we have some results that this model is the quality of life of patients with dementia and the reduction of caregiver burden is very important. But we need to collegate this practical experience with the scientific model and systematic review. We need that data, and we need other studies that can in this direction.
Hi, is this on? Yeah. Thank you very much for this fascinating session. Katrine Sia from the World Health Organization in Switzerland. Why this topic is really important to us is that based on some member states' requests, they're also asking for what is the evidence, what shall we do if we're reforming our healthcare system for dementia? Do we now actually establish these units or not? Are they effective? So I'd really love to stay in touch with you to explore your results further, and particularly any guidance on the cost effectiveness, how much are countries going to save, how many of these adverse or very costly institutionalizations can we potentially prevent, and also some kind of idea for how many or what percentage of people living with dementia might require such an intensive intervention. So more a comment and reflection, and really the invitation to stay in touch. Thank you very much.
Yeah, congratulations for good studies that you are doing. I can say that this can be maybe also good model for other general hospitals, because we face very often with problems when people with dementia are taken to the general hospitals, and in the hospitals, more or less, they don't know anything about people with dementia. And we know that when they come in the new space, they are afraid, they are completely in a bad mood. And often we hear from the carers who have people, a mother or father in the general hospital for different reasons. They broke a leg, a head, or arm, and then they call daughter, please take your mother from the hospital because she doesn't cooperate with us. So this can be good base also for other hospitals, and we also try in Slovenia to make training for people working in general hospitals. Really a lot of problems when people with dementia comes into the general hospital. So this can be good base, and it's good that we speak about this topic, and it can share your knowledge with other general hospitals. Thank you.
Thank you. The great question and comment. I might add that Alzheimer Europe will follow this project, especially in Brussels, and we will probably talk in the European Parliament about it. So let's stay tuned. Hopefully by February we will have some positive results. Yeah. So I'm thanking you for being here, and thanks to all the speakers, and see you in Brussels. Thank you.